Sir has been already introduced and he is going to take us through the emerging molecules pipeline in obesity care, and there's a lot in the pipeline. So over to you, sir.
So first of all, thank you, Dr. Jyoti Dev, Sunita, the entire team of JPEF. I've been a very big fan of Jyoti, and I love the two robots he is having. And thank you, chairpersons, for the kind honor. We are switching gears. We are into a Novo Symposium, though this is an oration. Future of adiposity, navigating the molecular pipeline in obesity care. So as I said, this is my duality and conflict of interest, and there are other people who also make GLP-1s who also are in that space. But I hope that what you listen, you learn and you adapt. So clearly, this whole therapy of GLP-1 should be more appropriately termed, and we don't use this term, called NASH. This is nutrient sensing hormone biology. And when we eat food, and we all ate food, there's a nutrient entry, and there are gut and pancreas signals, and they signal our brain appetite circuits, and they impact metabolic organs. And clearly GLP, GIP, amylin, glucagon, peptide YY are some of those peptides which are impacting satiety, gastric emptying, glucose control, adiposity, liver fat and inflammation, cardiovascular, renal or peripheral vascular risk. The FDA approved NASH therapies for obesity are liraglutide, semaglutide and tirzepatide. And we clearly recognize that interpreting for a pipeline, scouting, it is a class of a platform, not a single mechanism. Because it's impacting multiple metabolic organs. So there's a durable differentiation based on the route of convenience, oral or injectable, tolerability, outcomes. For example, we all know that semaglutide is a very outcome-driven molecule. Comorbidity evidence and so on and so forth. So if you look at the foundation, in the Novos table, for example, they have the semaglutide of step 1, 2, 3, 4, 5 and step teens. The potency and route is evidenced by OASIS 4, step up, redefine 1, 2, 3, 4 and reimagine. Organ outcomes in select, flow, essence and step heart failure with preserved ejection fraction. And we have a lot of pipeline in that whole biology of FGF21 in EFX, UBT1235, the amycretin or the zengamatide, evoke, the semaclo, the sema-select OSA and step 9. So if you look at the map and look at the left to right story, you can see the innovation and the expansion and the organ outcomes. So one thing is very clear, that the NASH therapies are here to stay. And the weight loss engine is here to stay. And the step established a clinical benchmark for a large durable weight reduction studied across populations and maintained with continuous therapy. You can even see now a 7.2 semaglutide reduces body weight by 21% in the step-up program. And you can see the drop of weight with a very favorable risk-benefit profile compared to say a 2.4 milligram semaglutide. So the science is having incremental innovation. And the discontinuation rate is very low comparatively compared to the molecule. We also see a rapid response, which is also alluded as early response in step-up post-hoc analysis, where you can see early response and sustained response. So you can see on the left and right of the graph, a very sustained and early responders, which are very clearly illustrated in this slide with different. We also see from step-up and step-up diabetes, a very sustained change over 72 weeks in waist circumference. And therefore, when you look at the potency and formulation ladder, we have a menu of anti-obesity therapies with weekly injectables, higher dose injectables, daily oral peptides, amylin combinations, and the next wave receptor biology. So it's a constant innovation in the obesity space. This whole thing was not there maybe 5 years back. So the core biology was GLP-1, but it's being combined with new biology and modalities. So from 2024, 2025, 2026, 2027 and 28, we'll see beyond GLP-1, amycretin, GIP, glucagon, and something more in novel and technology. So the big four are here. We no more talk of just GLP, GIP, we already know, and we have amycretin and glucagon also to speak for, which will look at the see and the feel of comorbidities, the convenience and affordability, the higher efficacy with traditional comorbidities, the upscalability, and not just high impact on weight loss and glucose control, but all the upsides on comorbidity or organ protection. So when we combine the four core biologies, we can not only impact diabetes but also obesity. So if you look at GLP, GIP, amycretin, glucagon, you can differentiate it with the various unmet needs, and we can look at the speed of innovation, and we can look at the scalability for patient access and price on comorbidities, tolerability, quality of weight loss, maintenance of weight loss, and preventive or curative mechanisms of action, and infrequent dosing and receptors. And therefore, when we look at this entire weight loss optimization pathways, we have 7.2 milligram semaglutide right on the corner of 2.4 milligram semaglutide. We have CagriSema, CagriSema HD, amycretin, which is zengamatide, and triple agents of GLP, GIP, glucagon, GLP, GIP, amylin. All are the next generation weight loss maximization. So we have already optimized weight loss, we want to maximize it. Also, we look at oral pills. We have first and best of class oral pill offerings in oral semaglutide, which will be upscaled now to 25 milligrams, and the oral amycretin, which is the zenagamatide. It's very well tolerated, and you can see CV inflammation and MASH also has some of these new pipeline drugs like the efuroxamine or the ziltivate. So if you look at the ladder of potency, you can see sustained weight loss readouts in the low 30s, and you can see very consistent body weight change. In the clanotide, you can see a very favorable safety profile with clinically meaningful weight loss. And in the Renew program, we saw that very clearly. We also saw that in the CagriSema phase 3 trial in overweight and obesity, in the redefined trial, a 22% reduction in body weight reduction, which is very clearly equivalent to bariatric surgery. We also saw that the CagriSema improved body composition. Remember, all these medicines are body composition medications. They not only cause you weight loss and fat loss, but the total fat mass relative to the total body weight loss. And you can see that the lean soft tissue loss is much less compared to the placebo, particularly in the CagriSema study. And when it looks at the Redefined 2 program, if you see CagriSema in obesity with type 2 diabetes, again some very, very robust evidence of reduction of both A1C 2.1% and weight loss 15 point or 16%. So very clearly you can see that diabetes does impact weight optimization and weight loss, but still we get a very sustained A1C reduction with body weight reduction. Amycretin is the next line, and very clearly you can see it's a GLP-1 receptor agonist and an amylin receptor agonist. And this entire compound, which is the zenagamatide, very clearly you can see is another game changer which will come in as molecules advance. And if you see this entire amycretin, very clearly you can see the acylation, the amylin receptor agonism, the GLP-1 receptor agonism is extremely well combined in the entire molecular pharmacology space, but robust outcomes. If you see the early phase 1A, 1B, 2A trials, which are dosing programs to efficacy programs. 24% weight loss without any plateau effect with 60 milligrams. Very clearly you can see in the phase 2 program a drop of A1C of 1.7%, a TITR, time in tight range, of a mean CGM of more than 91%, and a body weight without plateau in 15%. If you look at organ outcomes, which has been the core of the semaglutide program, the strongest differentiation is conversion of the metabolic pharmacology to cardiovascular, kidney, liver and heart failure evidence. In fact, these molecules have molecular pleiotropy because they are not just simple medicines which reduce weight or glucose. They have organ outcomes on heart, kidney, liver and heart failure evidence, on even peripheral vascular disease, even on the brain. And we have clearly seen that in the semaglutide story. Up to 26% of reduction of MACE with SELECT, SUSTAIN 6, SOUL and FLOW program. You can see a 24% robust reduction of major kidney disease events in the FLOW program. You can see mortality outcomes of all-cause mortality in SELECT and FLOW in 20% of cases. You can see in the ESSENCE program a 63% mass resolution and 37% reduction in fibrosis improvement. And even if you see on the pancreas, a remission, these are disease modifying drugs but also diabetes remission drugs, a 73% reduction in the risk of developing type 2 diabetes. So it's actually a remission drug, and semaglutide therefore has been proven beyond doubt. It saves lives, protects organs across patient populations with cardiometabolic diseases. So when it comes to organ-centric interpretation, head-to-head with tirzepatide, obviously semaglutide scores over in hard outcomes of atherosclerotic vascular disease and MACE. And we clearly see that semaglutide has placebo-controlled MACE drop in both obesity, type 2 diabetes with heart disease, which probably tirzepatide cannot match with. When it comes to hard outcomes with kidney and CKD, again semaglutide is currently stronger on hard kidney outcome evidence. When it comes to preserved ejection fraction and cardiac function and symptoms, again you can see a very robust symptom and function dedicated to obesity and type 2 diabetes clinical evidence. When it comes to liver histology, MASH and the label, very clearly you can see MASH label is very much there. However, of course, when it comes to OSA, tirzepatide has that OSA label in United States on it. Very clearly, as I told you, semaglutide is a pleiotropic molecule. It has a benefit of health beyond cardiometabolic system, and even in the frail people, an exploratory endpoint from SELECT showed the risk of MACE came down to by 30%. When you look at SELECT post hoc on people with obesity and asthma, the risk of asthma-related adverse events and SAEs came down by 42%. And when you look at biological age, when you look at multi-organ biological age, and when you look at the exploratory outcome of SELECT and step 3, clearly you can see a additional year which is gained, and that is why many people think that these NASH therapies like semaglutide might have anti-aging impact. What is the next wave? Broader than obesity. What is the next expansion, next formulation, next steps? What's the new era in obesity care? Well, I think the enabling will happen with oral medications. We all know that semaglutide has 94% homology with human GLP-1 with a half-life of a week. And you clearly know from the OASIS program that oral semaglutide 25 has completed the phase 3 trials. And clearly the 94% homology is very much there. We also recognize that in OASIS 4, the body weight reduction is 17% and the waist circumference reduction is equally robust. And more participants achieved a categorical body weight reduction with oral semaglutide in OASIS 4 compared to the placebo, with a very excellent safety profile. When it comes to oral zenagamtide, even in the phase 1 program, even as early as 12 weeks, a 13% weight loss has been seen with no weight loss plateaus. But as I told you, the biggest thing and the future of obesity therapy is all about body composition and all about how much of muscle mass is being lost. Because we all know from the step up pre-specified analysis, which was the MRI subpopulation on body composition, we know that semaglutide was weight loss 84% coming from the adipose tissue and only 15.6% coming from lean muscle loss. Because the most common question asked to me when I tell people to take a NASH therapy like semaglutide is, will I lose my muscle? And this is MRI analysis from the same. And as I told you, that clearly you can recognize a difference on gender and the reduction in the visceral adipose tissue volume, which is clearly recognizable. And if you see, the muscle function was preserved following the semaglutide treatment in the step up sit to stand test, which is a test for muscle function. And you can see that very, very clearly. If you repeat it also after 72 weeks, you can see that is a preservation in the muscle function. Why is that happening? In fact, when the Sema-Lean study was published, me and Shambho wrote a letter to the editor that the effect of semaglutide is beyond fat loss. But how is the muscle strength, metabolism and energy efficiency respond to semaglutide? And we know the answer. Because inside the muscle also there is fat. So what semaglutide is doing is it is losing that intramyocellular steatosis or the fat which is right inside that. And therefore there is a discordance on the lean muscle loss and the improved strength. Because in the Sema-Lean study, Alicia et al. Very clearly showed that high dose of semaglutide on body composition functional status in individuals with obesity had meaningful reduction in fat mass and reduction in lean muscle mass, but improvement in the muscle strength. And that was paradoxical. And the explanation for that is the intramyocellular fat and various other things related to energy expenditure. So as I told you, what was paradoxical is even if there is a 3 kilogram lean muscle loss, you get a 4.5 kilogram hand grip strength increase. It increases the muscle quality, not just quantity. And therefore we hypothesized improved neuromuscular efficiency, enhanced mitochondrial function and a shift towards oxidative muscle fibers if the intramyocellular fat is decreased. So clearly this is based, what was this hypothesis based on? On preclinical evidence that GLP-1 receptor signaling boosts ATP efficiency, mitochondrial biogenesis and the type 1 fiber proportion. So very clearly we have data to say, to explain this paradox, that though you may lose fat, you will lose proportionate lean muscle. Inside the muscle there is fat and you will get hand grip strength increase and that improves the muscle quality. Not only that, there's a lot of mechanistic insights where the resting energy expenditure dropped initially but normalized by month 12. This reflects adaptive thermogenesis. And the mechanism is the GLP-1 receptors are there in the hypothalamus. There are POMC neurons. So they may resist the resting energy expenditure suppression, which is via the central neuroendocrine modulation. Of course, we don't have direct thermogenic biomarkers for measuring back, like we don't have brown adipose tissue measuring or norepinephrine or thyroid hormone receptors. So clearly we have data from animal models that one group has attenuated response. If somebody has used GLP-1 in the past, there is possible receptor desensitization and internalization, down-regulated signaling and a pharmacodynamic ceiling. And animal models confirm that if there is chronic exposure, it reduces the GLP-1 receptor availability on the brain and pancreas. Also, there is a gender difference in response from Sema-Lean. And we clearly said that women had greater weight and fat loss than men. Because we all know that estrogen enhances GLP-1 signaling. Men have more visceral fat and are less responsive to treatment. And therefore, there is an implication for a sex-stratified dosing or therapeutic strategy we wrote in our letter. The other subgroup beyond gender is the post-bariatric subgroup. Because in the post-bariatric subgroup, there is a disproportionate lean muscle loss post-semaglutide. What is the cause? Is it additive GLP-1 peptide YY signaling post-surgery? Is it protein malabsorption? And therefore, you need to ensure that in this subgroup, we must do more of resistant training and protein intake. So what are our insights from the sema-lean or border composition? We have to look, as we evolve in future obesity therapy, we need muscle function, better strength despite of muscle mass loss. We need enhanced energy efficiency of the mitochondria. We need modulation of resting energy expenditure via hypothalamus by central signaling. Of course, we should be mindful of three things: that if you have prior exposure to GLP-1, if there is men or if there is a surgery, there is a likelihood of blunting of response. So we need those insights and we are getting them. So clearly we recognize that molecules like semaglutide are here to stay. It is more than weight. They enhance function, they modulate metabolism, they alter muscle physiology. And clearly semaglutide has something called as molecular pleiotropy. Of course, we need more mechanistic trials, biomarker inclusions, lifestyle integration, and sex stratified strategies. That's something which is there. So clearly, we have different approaches. And of course, because this is a Novo symposium and talk, clearly there is constant innovation. GLP-1, amylin, GLP-1 with amylin, triple agonist, FGF21 and old small molecules. We have greater potency with higher doses, organ protection, expanded indications, better formulations, and clearly a evidence base beyond obesity and diabetes to heart, kidney and the liver. So clearly we have disease modifying drugs. The pipeline of obesity has been cluttered and you can see it has never been so big. The NASH program which I started with, which is nutrient stimulated hormone biology and therapies, is huge. We just saw the trailers in semaglutide and you can see what is coming in: GLP-1, GIP, glucagon, amylin, and clearly we see an explosion of therapies which has clearly come up. Thank you so much for a patient hearing.
Thank you very much, sir. And you have taken us to the future of obesity care. Abhi to picture abhi baki hai. That's what semaglutide has told us. So thank you very much, sir. We will not take any questions because this is an oration and the inauguration is due.
Thank you.
Thank you.